COVID-19 is no longer a global health emergency, but the World Health Organization says it remains a global threat. We'll discuss the new variants that have some doctors worried. Hello, I'm Anand Naidu, and this is The Heat. The United States and the United Kingdom are among several countries experiencing an increase in COVID-19 cases. Hospitalizations rose 18.8% in the United States for the week ending August 19th, marking the sixth straight week of increases, according to the US Centers for Disease Control and Prevention. In the United Kingdom, more than 1 million people are believed to have COVID, and hospitalizations are at a 3-month high. The World Health Organization is monitoring 2 new variants and is urging countries to remain vigilant.
We continue to call on all countries to strengthen surveillance, sequencing, and reporting so we can assess the risk of new variants such as EG.5 and BA.2.86. And we continue to call on all countries to implement the standing recommendations to save lives and prevent the burden of long COVID.
For more on the COVID-19 variants, let's bring in our panel. Joining us from Lancaster in the United Kingdom is Dr. Mohammed Munir. He's a virologist and lecturer in biomedicine at Lancaster University. Here in the United States, Dr. Peter Chin Hong is a professor of medicine and an infectious disease specialist at the University of California, San Francisco. From Missouri, Dr. Zaid Al-Ali is the director of the Clinical Epidemiology Center and the Chief of Research and Education Services at Veterans Affairs St. Louis Healthcare System. Dr. Kate Telenko is the founder and CEO of Corvus Health, and she joins us from Alexandria in Virginia. Thank you, everyone, for being with us. Kate, let me start with you. So we have these 2 new variants, as we just heard the Director General of the WHO tell us, and that's the BA.2.86, nicknamed Pirola, and the other one is the EG.5 variant, also known as Eris. What can you tell us about these variants? I mean, how big a danger do they pose?
Well, first of all, there was more concern about Pirola because it has about 30 genetic changes, which is quite an evolutionary jump. Because, with these changes in the spike protein, there's a potential that the vaccine won't recognize it or that treatments won't be effective. But at least the first studies have shown that people who are vaccinated will be protected, will not have as severe disease as they would otherwise, and that the current tests will detect it, and that current treatments will work against it. So that is, and with Eris, we're still trying to find out more information. We'll know a little bit more in the future. But currently, just the general advice is to vulnerable people, or relatives of vulnerable people, to be a little bit more cautious, do more masking, more hand hygiene. But currently, it's thought the increase in cases is more due to the return of colder weather and kids back in school than a more dangerous variant.
So, Kate, you say those of us who have been vaccinated will be protected. Does that mean that the vaccinations that we've had already, they do give us some level of immunity?
At least some level. Preliminary studies have shown that it's less protection than with the older variants, but there is at least some level of protection, which is reassuring. And we should know soon about the upcoming new boosters and how effective they are against the new variants.
Ziad, there are some reports that say that those who've been infected with COVID before are more vulnerable to Pirola than others. I mean, is there anything to that?
Well, we still don't really know. I mean, it's really a new variant. We don't really know a whole lot about it, but we know, generally speaking, that infections and reinfections are consequential. I think there was a general assumption at the very early phase of the pandemic that if people get it twice, the second time around it's totally inconsequential. And maybe milder the second time around, but it still contributes risks, both in the acute phase. It could still put people in the hospital, or even worse, put them at risk of death. And also we worry about the long-term consequences of reinfection in terms of increasing the risk of long COVID.
Right. And Ziad, hospitalizations are up in the United States, up to 10,000 people being admitted each week. What are you seeing in terms of who is being admitted to hospital right now? I mean, is there a sort of something common to the profile that you see?
So generally, people who get hospitalized here, anecdotally, in our hospital system and throughout the U.S. and actually in the world, generally older adults with comorbid conditions and people who are immunosuppressed or on chemotherapy, et cetera, et cetera. So that's really sort of but that's not everyone. There are some instances where kids are being hospitalized and younger adults are being hospitalized. But in general, the people who are at higher risk of being hospitalized for any COVID, including the new variants, are generally people who are older adults and people with comorbid conditions or diseases that predispose them to higher risk of COVID-19 illness.
Okay, Peter, good to see you. There are those of us who have taken up to 5 vaccine shots, but now the Centers for Disease Control and Prevention, the CDC, is expected to review updated vaccine boosters, and these are boosters which are being produced by the big pharmaceutical companies, Moderna, Pfizer, Novavax. Who should be getting these boosters, and are these boosters formulated in a way to protect us from the new variants that we see?
So those are great questions, Anand. I think, first of all, the lowest hanging fruit are those who are older than 65. I would say age trumps everything in COVID morbidity or serious disease. And of course, another group would be those who are immune compromised of any age. I think that, as we wait for the CDC recommendations, it will be offered to everyone. And I think it's good for everyone to get it, but again, prioritizing those who are older and immune compromised. In terms of whether or not it will work, it depends on what your definition of working is. If it's reminding the immune system so that you stave off hospitalizations and death, I think it will be generally, or I predict it will be an unqualified success. But if it's preventing infection or giving that force field, it probably won't be as good depending on what variant hits. If you look at ERIS, EG5, that is very similar to XBB 1.5, which the vaccines were based on. But if you look at Parola, BA 2.86, that's, as Kate points out, 30 mutations different, so it may not have such a big force field against infection.
And Peter, when you say immune compromised, those are the people who have underlying health concerns, health problems.
Yeah, so I think that's a great question, Anand, because I think there's a lot of confusion in the community about what immune compromise means. To me, immune compromise is not the same from one person to the other. There's very immune compromised. That is somebody who I'm not confident will get an antibody or a cell-mediated response to infection or vaccine. So those who are within 3 months of a transplant, those who are taking therapies that might wipe out their immune system, particularly their B cells and T cells, or those who are, otherwise expecting to be in one of those states. So, your person with diabetes is relatively immune compromised, but those people are generally well, and we've looked at data around that, have decent antibody responses to vaccines and infection.
Mohammed Munir, great to have you with us. Now, in the United Kingdom, authorities there tell us that they will move the start of the flu and COVID-19 vaccination program up to this starting next week, actually, beginning next week. What is the situation in the UK, and who will be getting those new booster shots?
Yeah, well, thank you very much for having me. As we all know, that overall surveillance is really wound down. So therefore, it's very difficult to anticipate what is the level of infection in the country. But in the UK, the perception has been that there has been a while since the vaccination has been at that level to have a vaccine-induced immunity in the community. So now the immunity is waning, the antibodies are going down, and on the face of the new variants, particularly with the BA 2.86, which has a significant level of mutations, probably that new variant would not be held quite nicely within the community. Therefore, the vaccine program has been put forward and people with any vulnerabilities, these are prioritized. In the healthcare workers, those are prioritized. People age 60 and plus, they will be prioritized for this new vaccine campaign that has been brought forward.
Right now, Mohammed, you were saying that the surveillance program by the British National Health Service, that has been closed down. Well, it hasn't been closed down, it's been scaled back. And of course, scientists, epidemiologists need data. So the fact that it's been scaled back, how is that impacting what kind of data you're getting?
Yeah, absolutely. I think this is an important question, and probably important to highlight is that, I mean, in the midst of the pandemic, we have a great surveillance, not only in the UK, but across the globe. But since the beginning of this year, almost every country has really restricted what they spend onto the surveillance, which is really the major reason that when we come across the new variants, those are already prevalent in many countries. For example, just 2 weeks or 2.5 weeks before we first came to know about Parola variant, but now over a dozen of countries have already been reporting. So it is really critical to understand what kind of variants are circulating, because until we don't really know about them, it's very difficult to put any control and the stringent measures in place. And I think really to put into the context that, for example, this Parola has more mutations than Omicron got from Delta. So it is really a significant one and could probably be one of those variants that could escape the immunity. Although it's a very early stage, few studies have been conducted and a lot more to understand about this variant.
Kate, schools in the United States will slowly start reopening as summer draws to a close. But there are schools already in the states of Texas and Kentucky that are closing down because of COVID-19. Our reporter Tony Waterman has been looking at this. Let's listen and watch what she has to say.
Classes in Magoffin County, Kentucky had barely settled into the rhythm of a new school year when they came to an abrupt halt. All 5 of the district's schools were shuttered for 2 days last month amid an outbreak of illness, including the stomach virus, strep throat, and COVID-19.
Usually we see a lot of illnesses when school starts back among the younger students, but this was kind of spread out all the students too. My understanding, they had some custodians, bus drivers, and also that were absent too with the COVID, which also made it difficult to run the school too.
Magoffin Public Health Director Pete Shepard says local doctors were reporting 40 new cases of COVID a day among kids. That didn't include positive at-home tests. Attendance plunged to 83%.
If the attendance gets below a certain number, then you start losing state money. So they decided to shut down and just try to nip in the bud before it got started full-fledged.
Schools in other parts of Kentucky and South Texas were also forced to temporarily suspend classes as a late summer surge in COVID-19 sweeps across the country. While case numbers still remain well below the height of the pandemic, the latest data from the Centers for Disease Control and Prevention show an increasing number of tests are coming back positive, while hospitalizations nationwide have risen for 6 consecutive weeks. Experts say a relaxation of COVID precautions like masking and distancing is largely to blame.
I think it's also compounded a little bit by the heat waves that we've had that have brought many more people indoors to really protect themselves from the extreme weather, extreme heat that we've had. And that has, I think, also facilitated some transmission of COVID over the summer months.
According to the CDC, 96% of Americans over 16 years old now have some level of immunity to COVID, from vaccination, infection, or both, which could help limit the number of severe cases. In Magoffin County, Pete Shepard says symptoms among students have been mild, and for now, there's no talk of reimposing COVID safety measures.
COVID's not going away. It's here. It's going to come. As each one of these things mutate, it's going to keep, we're going to have another one and another one and another one.
Which means another unpredictable school year. Tony Waterman, CGTN, Austin, Texas.
So, Kate, as you were telling us earlier on, we should continue to take those precautions that we started taking when this pandemic broke out. But with these cases on the rise right now, should schools, or for that matter businesses, reintroduce things like masks and those precautions that we talked about? Or will this outbreak be treated as just another virus?
I don't think we're going to see a return to mandated masks or social distancing. I think that people will do it voluntarily based on their risk or their comfort level. As you heard in that report from Texas, they were shutting down more for financial reasons, or some schools are shutting down more because they don't have the teachers or they don't have the bus drivers because they're out sick. So I think it will be a very different reaction this autumn than, school years in the past. One thing that does give me hope is that, we now have the RSV vaccine for seniors and for pregnant women, and that will protect them from RSV, because we're often seeing people getting multiple infections, flu, COVID, and RSV, which is more dangerous than having one infection by itself. Another thing that encourages me in the U.S. is the U.S. government has now started negotiating drug prices for Medicare. Now, currently, they're just focusing on chronic disease medications like diabetes and high blood pressure, but I can see in the future them starting to negotiate prices on COVID-related drugs.
Peter, Kate, I was talking about the RSV virus. There are fears over this. The Food and Drug Administration has approved a vaccination. What can you tell us about this virus? And could we have a sort of triple whammy, a trifecta of this virus, as Kate pointed out a moment ago, this virus, COVID, and the flu virus hitting us at the same time?
Well, and RSV is a respiratory virus. It's kind of the bronze medalist of the respiratory viruses. So COVID and influenza vie for the gold and silver, and RSV is always the third. But the reason why I think we worry about RSV is that it causes a lot of kids in particular to go to the hospital. It causes deaths and hospitalizations in older adults. And most importantly, we don't have any therapy for RSV once somebody has it. We don't have an RSV antiviral. So it's really important to prevent it. So I think this year with the vaccine, depending on how many people take the vaccine, could really shape what our winter looks like in terms of a triple-demic. I think if it weren't for the vaccine even, it may be a little bit lighter than last year because some immunity gets carried over from the previous year. And because we didn't have immunity in 2021 and 2022, that's why the 2022 season was really terrible. So that's why, I think it may be a lighter season with RSV, but it will still cause a lot of people to go to the hospital and get sick.
Ziad, the CDC tells us that there's something like 15% of Americans who suffer from what's known as long COVID, and about 6% of them are still struggling with this. And the symptoms that they experience are fatigue, heart and respiratory problems, frequent headaches, loss of taste, stomach pains, as we've heard. At this stage, do doctors know more about long COVID and these symptoms and how long they last?
Sure. We know a lot more now than we did 3 years ago about long COVID. We know it can affect nearly every organ in the body. It can affect the brain and the heart, can affect the GI system or the gastrointestinal system, can affect the kidneys, can actually even in some cases lead to increased risk of diabetes, et cetera, et cetera. So it really can touch every system in the body. And it can also affect people across the lifespan. This is not really a disease of young people as has been portrayed in the media. It can also affect children and older adults. So really everybody across the lifespan is affected. So we know a whole lot more about it, but we don't know at this point is really how to best treat it. There are multiple trials that are going on right now to help us understand what treatments work for long COVID, what treatments don't work for long COVID. But that's really an evolving field. So definitely better than we were 2 or 3 years ago, but there's still a lot of work that needs to be done. And we're calling it for it to be done as urgently as possible, because as you pointed out, millions of Americans are suffering and millions of people throughout the world are suffering from long COVID, and those people need treatment yesterday. So it really needs to be done as soon as possible.
Mohammed, as we were talking earlier on about the fact that surveillance systems have been shut down or scaled back, the World Health Organization is very, very concerned about that. Here is Maria Van Kerkhove at the WHO, and this is what she had to say about it.
surveillance has declined massively around the world. And so we don't have a good indication of how many cases there are, either of infection or reinfection. And in fact, we only have half of the world's countries actually reporting cases right now. That does not mean that the other half don't have cases. It just means that they're not reporting them anymore. You know, and the gains that they made across all of these aspects, surveillance, clinical care, infection prevention control, everything that they did for COVID-19 is an investment for the future. It's needed for the current threat that we face with SARS-CoV-2, but for everything else that we're going to face. So dismantling those systems is really short-sighted.
So, Mohammed, what is it going to take to get those systems back and running again?
Well, I think this is really important because we already have had that infrastructure in place, not only in the developed country, but also in developing countries, and bringing that back onto the same level or at an acceptable level is not going to be a difficult thing. But of course, it requires investment and initiative from the government. But I think this is started to be realized. For example, in the UK Health Security Agency, they have indicated that they're going to bring back some of the surveillance in the community level to understand what kind of variants are circulating and what level they are circulating. And understanding, once again, to emphasize, is really critical to devise any control strategies, because if we are not going to be aware what is happening in the real world, that basically it would be equivalent to shooting in the dark.
Kate, more than 1 million people have died from COVID in the United States, but here's a problem that's a little bit, of course, outside the realm of medical science, and that is that this has become very, very politicized. This is what former President Donald Trump, and now, of course, he's running for president again for the 2024 presidential election. This is what he posted on social media last week. Let's listen.
But to every COVID tyrant who wants to take away our freedom, hear these words: we will not comply. So don't even think about it. We will not shut down our schools. We will not accept your lockdowns. We will not abide by your mask mandates. And we will not tolerate your vaccine mandates.
So, Kate, how does the medical community deal with the kind of disinformation that we're seeing, and what's become a very volatile political issue?
Yes, it's a huge challenge. And some people say that the U.S. is even less prepared now to address the pandemic than it was before, because this misinformation has become hardwired into American society. And so the medical profession really has been trying to engage more communication specialists, especially people who understand the psychology of this type of communication, so that that messages are communicated by people that communities trust. But as I mentioned before, I think because of this general resistance, we won't see mandatory masking, or we won't see lockdowns again. And it's a huge challenge worldwide.
Peter, these concerns that Kate was talking about, they've also been expressed by Dr. Anthony Fauci. Of course, he's one of the infectious diseases experts here in the United States. There are now very deep concerns over vaccinations as well as the use of masks. How serious a problem is that going to be?
I think it's a very serious problem because it's not only about COVID, it's about all the infectious diseases we have. It's for all the reasons that we might wear a mask. It's for all the reasons we might give a vaccine. So if you carry over or spill over your hesitancy around COVID into other aspects of healthcare, that's really, really scary. And case in point, polio, in the Northeast in New York State, measles in other parts of the country. These are all examples of increasing vaccine hesitancy that's really catalyzed by COVID.
So you're seeing this not just in instances of COVID, but in other viral infections as well, people being resistant?
Yes, I mean, and I think you bring a mask out and everyone thinks it's a political statement, but rather it's really something that we use every day in medicine, in the surgery, in the operating room, in healthcare. And I think for people to really have that resistance against masks really speaks to, it is a metaphor for just trust and lack of trust of health professionals versus political rhetoric.
Right. And Ziad, looking again at long COVID, the CDC says that it's most prevalent in people aged 35 to 44. What is your research showing?
So it's really clear that there are multiple types of long COVID. There is sort of the type that's characterized by brain fog and fatigue, and that tends to be more common in younger adults and more in females than in males. But there are other consequences of SARS-CoV-2 infection that we actually also classify under the broad umbrella of long COVID, including metabolic conditions, heart problems, strokes. Those tend to happen in older adults. So long COVID is not really a monolithic thing. It's not one thing. It's not just one symptom or one thing. It's really more than 200 health problems that can happen after COVID-19 and linger for months or years, and that really needs to be taken very, very seriously.
Right, and is there any kind of treatment for it at this stage?
No, unfortunately not. And we know the best way to prevent long COVID is actually to prevent COVID in the first place and prevent infection or reinfection with COVID-19. And vaccines do reduce the risk of long COVID. Antivirals and those who qualify for them, not everyone will qualify for antivirals, but antivirals and those who qualify for them also reduce the risk of long COVID. Unfortunately, at this point in time, we don't know that we haven't really yet discovered treatments that works for long COVID.
Mohammed, looking at the situation now, I mean, this is several years after the initial outbreak of the pandemic. Do you believe that the world is better prepared now?
Well, unfortunately, we do learn quite quickly, but we do unlearn equally quickly as well. I mean, there are many lessons that we have learned over the course of 3 years of this pandemic, but many of those are not being practiced at the time when it is needed. But I would say that, no, we are not prepared, and there's still a lot to carry over for not only just this virus, because it's not done yet, but also there are equally impactful viruses out there which could have the same impact as COVID-19 has onto the humanity. But as it stands, from infrastructure-wise to the policy-wise to the support for the low and middle-income countries, and also to invest at the level when it is required to the extent to bring up the treatments and the vaccines at the scale that is needed globally. All those things still require to be thought through and practiced.
Okay, and that is where we are going to have to leave it. Thank you to all of you for being with us. That is it for this edition of The Heat. I'm Anand Naidu in Washington, D.C.